Hi everyone, it's Dr. Hall. Welcome to lecture 24. We're going to talk about a few of the mood disorders, starting with major depressive disorder. So the outline for this lecture is, as mentioned, we're going to start with depression, then we're going to talk about generalized anxiety disorder and post-traumatic stress disorder, or PTSD. Starting off with major depressive disorder. So what is depression? What are we talking about when we talk about MDD or a major depressive disorder? This is a severe and pervasive low mood that lasts for weeks that ends up causing distress and or impairment in somebody's ability to do their daily life. That could be in terms of impairing their ability to do work or school, or impairing their relationships with other people, or certainly leading to thoughts of suicide and self-harm. It occurs in about 10 to 20% of people at some point, at least in their lifetime, and it can often be recurrent, although it isn't always. So it's characterized, as you would imagine, by feelings of sadness, but there's also guilt, low self-esteem, and hopelessness, sometimes anger as well as decreased energy and motivation, a lot of social withdrawal, not doing things with people anymore, trouble with sleep, often trouble being able to sleep, although sometimes in atypical cases, people are sleeping a lot extra, usually loss of appetite and difficulty with concentration. One of the other interesting symptoms is what is referred to as anhedonia. So hedonism, if you've ever heard of like the all-inclusive resort, hedonism is like living la vida loca, right? It's just like enjoying life, all of the things that life can bring to you. And so anhedonia is a lack of ability to feel pleasure. So people will describe, yeah, I used to love gardening, but now it just doesn't do it for me anymore. I used to love to go out and hear live music at a bar, and I have no interest in doing that. It's just not enjoyable for me anymore. So these are the symptoms. They are severe and pervasive and don't go away. Now, I want to, keep reinforcing that, because when we talk about the mood disorders, we're talking about severe, pervasive, and not going away. All of us have times when we feel a lot of these symptoms. That is a normal part of human existence, to have sad days and low days and days where you don't feel like doing anything and nothing seems at all enticing to you. That is normal. But if it doesn't go away, then it might be major depressive disorder. So what is causing it? So what's going on to cause it? So on the left side, it says causes of depression, and a lot of these are just risk factors. These are things that we know put people at increased risk. So stressful life events, certainly. Biological factors. So there does seem to be some genetic predisposition, for sure. Substance abuse can complicate everything, and although it's not clear that it causes major depressive disorder, it can certainly complicate efforts to treat it and recover from it. Certainly some types of psychological factors, some personality types, some ways of kind of approaching the world can put you at increased risk. But then there's this kind of brain structure and function area. So like, what's happening in the brain that is going on in people who have major depressive disorder? And so there are kind of four major hypotheses. Three of these are talked about in the book. Another one is talked about in the 10-minute neuroscience video. So we're going to go through them one by one. And these are not mutually exclusive. It could be yes and some of them are more well fleshed out than others. So one of the first ones to come along was the monoamine or serotonin hypothesis. This came about because of a drug called isoniazid that was used to treat tuberculosis, interestingly, that was found to have a side effect of helping treat people's depression. So that was kind of nice. And so they were like, well, what's going on? And they realized that that medicine interferes with the enzyme that breaks down serotonin in the body. They also then found that the tricyclic medications, which also inhibit some reuptake back into the synapse of serotonin, were helpful in treating depression. So norepinephrine is also a neurotransmitter that is a monoamine. They have one amine in their molecular structure. Dopamine is also a monoamine. So when you hear monoamine, they're referring to this group of neurotransmitters that have this chemical similarity to one another. But as we know, different neurotransmitters do different things, and sometimes the same neurotransmitter does different things in different synapses, just to make it complicated, right? So you already know that this isn't going to be an overly simplistic explanation of what's happening. But what this led to was the development of medications specifically targeted to prevent reuptake of serotonin or norepinephrine, right, from the synapse. And so they stay in the synapse longer. And so the idea is, okay, these people maybe don't have enough of these neurotransmitters, so we're going to make those neurotransmitters stay in the synapse longer. Therefore, they're going to get more of the effect, and it will improve their depression. And in fact, these medicines are highly effective for many, many people. Are they a slam dunk for everyone? No. Are they happy pills where as soon as you start taking them, you're like, yay, everything's better? No. What a lot of people will describe with these medications is that before felt they were just kind of falling into this big yawning pit of black nothingness. Now they feel like there's a floor underneath their feet. Right? So it's not a happy pill, but it seems to help take away some of the worst of the darkness associated with depression. So this hypothesis is kind of nice, but it doesn't completely hold water. And so in the 10-minute neuroscience video, he talks about some of the holes in the hypothesis. One of them is that we know that the medications change serotonin levels in the synapse right away, but the depression symptoms, although some people notice an effect pretty soon, it really takes weeks to get the full effect. So it doesn't kind of fully hold water. Another hypothesis has to do with the hypothalamic pituitary adrenal axis that we learned about when we learned about with the stress reaction. So we know that people that endure abuse and chronic stress, they are at increased risk for depression. We also know that people with major depressive disorder often have an overactive HPA axis. They will have higher cortisol levels than other people. Now, this is kind of tricky because if you're sick and you don't feel well, maybe that's triggering your stress reaction. So it's a little bit of chicken and the egg, what came first? Not really entirely sure. But we do know that chronic high cortisol levels, so remember when we talked about chronic high stress, we said it can lead to anxiety and depression. And we also know that it disrupts the function of the prefrontal cortex, the hippocampus, and the amygdala. So there's this idea, right, that for some reason, maybe these people's HPA axis, either as a result of trauma and chronic stress, or just biologically is overactive, and that could be causing the depression. It's a good hypothesis. We're still trying to figure it out. The other is the anterior cingulate cortex dysfunction hypothesis. This one is mostly kind of generated by the fact that the ACC, as we learned previously, is responsible for emotional regulation. So remember, the insula is taking all this sensory information and attributing feelings or emotions to it, and then the ACC is deciding how we're going to express that and what kinds of decisions we're going to make based on those emotions and feelings. And so we talked about how people with emotional dysregulation that have very big reactions to emotionally charged events often have decreased activity in their anterior cingulate cortex. So now with technology, we can look at functional MRI. So somebody's in an MRI machine and we're able to see differences in areas of the brain depending on when those areas are active or not. And we definitely see differences in the anterior cingulate cortex in people with major depressive disorder, and especially in terms of how it communicates with other areas of the brain. So the image that we're seeing on the left is from a study that was done looking at functional MRI and looking at people who had major depressive disorder and comparing them with controls. So what we're seeing with the red or the green solid arrows or dotted areas is is places where there's increased connectivity, increased excitatory activity, decreased excitatory activity, increased inhibitory activity, or decreased inhibitory activity, right? So there are these functional differences that they're able to see and how their brain is talking to one another. Now that diagram might look kind of like, that's so sciencey and complicated, but let's break it down a little bit. So in the middle there, you see there's some little initials, but then it's ACC. So these are different regions of the anterior cingulate cortex. And look, PFC, prefrontal cortex, you know that it's important in mood regulation. And the insula, right? That's the insular cortex. So you know that that's important. We learned about that too. And then the amygdala. So these are old friends. You already know these structures. We learned about them in lecture 23. But it's just kind of cool to see, like, this stuff is real. The last hypothesis we're going to talk about is the immune system dysfunction or inflammation hypothesis. Now, I want to be clear that inflammation is activation of your immune system. So whether it's good or not good depends on the situation. If I have a bacterial infection of a splinter that I got and it gets all inflamed, that's my immune system trying to treat the infection, right? So that is a normal adaptive response. So I just want to be clear that inflammation, which just means activity of the immune system, may or may not be a good thing depending on the situation. I think out in the lay language, like, oh, inflammation is bad. I'm like, well, if you're sick or infected, it's good, right? It's what you should be doing. Okay, I'll get off my soapbox. So what we see is that some people with depression have signs of elevated immune system activation. Now, what is this diagram on the left? So they're thinking that, in ancient hunter-gatherer times when humans were evolving, it made sense for your immune system to be relatively trigger happy, right? You were often getting wounded. There were all types of germs in the environment. You didn't necessarily have clean water or soap. You certainly didn't have antibiotics. So you can see it says inflammatory bias, right? So your immune system was like ready to jump in at any moment. So then they kind of talk about as, the evolutionary time kind of moves on. Then as things got a little bit more hygienic, right, we started developing ways to realize that some bacteria or some germs are old friends, that they're actually not dangerous to us. They can actually even be helpful to us. And so we started modifying our immune systems to tolerate that. And then they're talking about how in modern life, your risk of dying from an infection, now that we have clean running water and soap and antibiotics and vaccines and all the amazing things that have vastly improved our life expectancy, like doubled it, that this increased inflammatory kind of trigger has outlived its usefulness, right? So they're saying it's kind of too trigger happy, and now the risks outweigh the benefits. That's the idea. So we're not really sure why or how this may develop. There's also some really interesting research looking at the microbiome, which is the collection of, especially in the gut, so the collection of bacteria and other microbes that live in your intestinal system, and that they're actually very important in signaling the brain and regulating mood. So there's all kinds of really interesting research happening in this space that we just don't have time to go into, but it's fascinating. So I encourage you, if you're interested, to seek that out. So the last thing I'm going to finish with talking about this idea that it could be immune system dysfunction is that we know that, I think I mentioned this, I can't remember, in people with depression, they do have markers of increased immune system activation. So it does appear that their immune systems are activated, right? And think about how you feel when you're sick, right? You feel tired, you have low energy. Excuse me, I'm not sick, I just swallowed wrong. You don't want to do anything, nothing appeals to you, right? So a lot of these symptoms when we're sick are triggered by these chemicals released during an immune response. And if you give healthy people, healthy controls, those chemicals, right, it can induce symptoms similar to depression. So as another aside, a lot of times people are like, oh, I don't want to get the flu shot because I always get the flu from the flu shot. You do not. You get the immune response, and the immune response is part of what makes you feel sick, because those chemicals actually make you feel tired and yucky and achy and all those types of things. It's actually your immune system's response. But anyway, There we go. How do we treat major depressive disorder? Psychotherapy is a mainstay and it is very effective, especially cognitive behavioral therapy. So remember when we talked about emotional regulation, we talked about cognitive reappraisal. This is changing your mental frameworks, changing those scripts that one TED Talk guy talked about, and changing the lens through which you view the world, and that can be really helpful. Medications like SSRIs, so they prevent serotonin reuptake in the synapse, are often very helpful for many, many people. And then supporting the body and the brain as best you can. So eating healthy foods, make sure you stick to a schedule, get sleep regularly, exercise and move your body is incredibly effective. There was a randomized controlled trial where they randomized people with mild depression, like this is not for moderate or severe, but relatively mild major depressive disorder, to either an SSRI or an exercise program. They did just as well. So exercise, who knows how, somebody might, I don't, right, is able to help foster healthier connections in the brain. And then get out. By that, I mean get outside, going out in nature. In some cultures, they talk about taking nature baths as a therapy, and also get out and make yourself go do things with others, even though you don't feel like doing it. That can help, right? Kind of some of the fake it till you make it. And then the last thing is electroconvulsive therapy. I don't know who ever came up with this idea of administering electricity across the brain and inducing a seizure to see if it would help treat depression. But somebody did, and lo and behold, it is incredibly effective. I worked in an inpatient psychiatry unit for a time during my training, and we had someone with severe depression that wasn't getting better with medication and psychotherapy and behavioral interventions. And so they did ECT, and it was a miracle. It was a miracle. This person who had been so debilitated for so long by severe depression and was basically cured within the space of a couple of weeks. It was really powerful. So there's a video in the media assignments for you to watch about ECT, because it does get a bit of a bad rap. How does it work? We have no idea. It's like a reset button, right? It causes all the neurons to like discharge at once, and then like, I don't know. So those are treatments. Oh, one other thing I will say about that is now they're also looking at deep brain stimulation. So doing stimulation either with electrical current, but at a lower level, or sometimes even with magnets to see if maybe they can get similar effects. That's still experimental for the most part, but being used in some clinical settings as well. All right, so this was a long one. So major depressive disorder is a persistent and severe low mood that does not go away, that lasts for many weeks. And it's accompanied by feelings of low self-esteem, guilt, hopelessness, anhedonia, which remember is lack of taking pleasure in things that are normally enjoyable for you, difficulty with energy levels, sleep, motivation, concentration, low appetite, social withdrawal, and then, of course, sometimes suicidality as well. So this can be a fatal illness, right? Risk factors include family history and environmental stressors. And we have these kind of 4 different hypotheses for what's happening in the brain that we talked about. The monoamine or serotonin hypothesis, that it's just you don't have enough serotonin in your synapse. The HPA axis dysfunction, that this high cortisol is part of the problem that leads to brain dysfunction. The anterior cingulate cortex dysfunction one, to say it's mainly a problem with emotional regulation. Or this immune dysregulation, chronic inflammation idea that may also be related potentially to your microbiome, which is also pretty interesting. So this is a very, very treatable condition, but people need to get treatment for it, which is sometimes hard when you're feeling really, really depressed. The last thing you want to do is like go out and go to counseling or make a doctor's appointment and all those types of things. But it's important because this condition can be terribly disabling and can be fatal, and treatment is effective. So psychotherapy, especially cognitive behavioral therapy, is one of the best studied for treatment of depression. Medications like SSRIs, there are others, but those are the most commonly used ones. and then ECT or deep brain stimulation for depression that is not getting better with the above. All right, that's it for 24A. See ya. Stop.